the right way where the esophagus isn't attached.
All right, it's an opening in the trachea. What else?
Or it's an opening of the esophagus to the trachea.
All right. So if it can be one or two holes, what are the two connection pieces?
Atresia? Is that?
What are the two connection pieces? What's connected?
It's the trachea and the esophagus.
The lumen of both structures are connected so that there will be a direct passage.
If you're saying anything.
Hello, can you hear me now? Hello?
Take yourself off mute.
I did. Hear me? Hello? Hello?
I can hear you, Okizi.
Okay. What about now?
Oh, I think that was me, but go ahead, try again.
Okay. All right, ma'am. I said that it would be a direct connection of both cannulas of the esophagus and the trachea, so that there will be a direct passage of, say, any food or liquid that's swallowed through the esophagus into the trachea.
Okay, so there's a combination of saliva from above coming from the trachea, and it's going to mix with gastric secretions from below that's going to flow directly into the tracheobronchial tree. Is that what you're saying?
I was just thinking about anything that's swallowed only from the esophagus into the trachea, and then that will be down to the bronchial. I didn't think of the saliva or mucus from the bronchial part as well. Sorry, from the trachea as well.
Okay, so anything including the saliva.
Okay.
No, I'm asking you. So anything including the saliva. So saliva from up top, gastric secretions from down low. So if you have gastric secretions, is that a good thing to go into the tracheobronchial tree? Or into...
No, it wouldn't be a good thing. It should be only air.
All right. How does one develop this fistula? Because a fistula is basically, it's a connection between, two organ components or tissues. So this would be, the particular organ in question would be the trachea and the bronchial tract. So when you have a fistula, then you have two connections, or you have a connection of two different structures that normally are not connected. What puts a person at risk for developing a TEF?
If you have maternal history of polyhydramnios, or however you say that.
Okay, it is an early fetal development, Erica. Say that again. Is that you, Daniela?
Yes, I said if the mom has a history of polyhydramnios.
Okay. So you're looking at from the mother perspective.
Yes.
Okay. What else?
I would say that intubation can also cause it, or any process or procedure that would introduce a foreign, let's say, agent into the esophagus can inadvertently cause some injury.
Well, somehow this has to do with the fetal development. So they're not really sure of the exact cause. but they do see a TEF is more common in individuals that have like intestinal problems or skeletal problems or central nervous system anomalies. So in that developmental process, either there's a heart condition, so there's a congenital heart disease, there's a genital urinary disease or anomaly, there's a GI anomaly, a central nervous system anomaly. So there's a couple different reasons why or associations that you would see with a TEF. So they could have a heart defect, they could have ear abnormality. So these would be associated syndromes with a TEF. But during development, during that fetal development, those individuals, it's a result from the esophagus or the embryonic esophagus failing. There's a failure in that process, and the trachea to develop and separate correctly. So the esophagus and the trachea somehow have an abnormality where they don't separate. When do we normally have respiratory system development? Not the lungs, just the entire system where things are actually in place. How many days of gestation? Four weeks? A little bit more, but about 26 days. So we're looking at about 6 weeks. So that's when the respiratory system development starts. And if there's an abnormal development in the septum, then this can actually lead to TEF. Okay, there's different types. Your book kind of points it out that there's a type A, there's a type B, all the way to H. However, the most common type is C, where you will see this, the tracheoesophageal anomalies. Okay. All right.
Did you say type C?
Type C as in cat.
Okay.
So they kind of combine the TEF with esophageal atresias. So when you look in your Horse Point book and Lippincott, they'll be there together on page 943. But they're gastrointestinal anomalies. So the trachea and the esophagus do not separate during the embryonic development.
So TEF is not atresia, or they're separate?
Say that again.
Are you saying that the TEF is separate from the atresia?
An esophageal atresia?
Yes.
Yeah, yes, because when it's associated with an esophageal atresia, then the fistula is most commonly occurs between the distal esophageal area and the trachea. So when you're looking at a TEF, when you have that connection, then you have two of them going on together because trachea and esophagus haven't separated. Remember, they share the same smooth muscle. So the posterior portion of the trachea is the anterior portion of the esophagus. Although they're separate structures, that layer divides the two.
Okay.
Okay. So now there's a connection between the two, but there is an incomplete separation of those two. And then when you're looking at a tracheoesophageal fistula, then that's more of, now we get the lungs involved. So it's at the lower portion, or where we can have stomach contents that can actually get into the lung tract, which is not what we want because of that connection. But it is from the polyhydramnios. So that's kind of one of the things you want to see if they've had the mother. but that's usually in an esophageal atresia when you'll see that. Okay.
Mm-hmm.
There's 3 C's that they talk about as their hallmark signs to a tracheoesophageal fistula.
Crying, coughing, cyanosis, and choking.
So coughing, choking, and cyanosis are the 3 C's that you will see. So the newborn may have rattling respirations, a lot of saliva, they may be drooling. So we're looking at if they're coughing, if they're choking, and if they have cyanosis, if feeding is attempted. So when the mother's trying to feed the baby, then these are the things that the baby will experience. So with this fistula, the risk is increased for respiratory complications like pneumonitis and things like that. So your 3 C's, choking, coughing, and cyanosis with feeding is considered the classic signs of tracheoesophageal fistula and atresia. So for both of them. So they're similar, but they're different. Their signs and symptoms are similar. What does atresia mean? What is the definition of an atresia?
Is that disconnection?
It's an abnormal narrowing of an opening.
Okay.
So atresia means it's smaller or it's non-existent. When you have a fistula, that's an opening, that's a connection, but it's not necessarily narrow. Does that make sense? Yes, no, maybe.
Yes.
Yes.
Okay. All right, so I have a brief Word document that I'll show you real quick. Let me figure out how to do this. We'll share my screen. So can you see that? Can you guys see that?
Yes.
Yes.
Okay. All right, so 3 C's. You're looking for choking, cyanosis, and coughing with feeding.
Okay.
That's the key there.
Okay.
So say that again. Okay. So what I wanted to show you, here's your normal anatomy of your trachea and your esophagus, then your stomach. So now, if you have an atresia, which is a narrowing or non-existence, then here is the trachea, but this is just one version. It doesn't mean that they all happen this way, and I'm just gonna make it a little bit bigger. So in one version, the trachea stops, the esophagus stops, but here's your fistula connected to the lower portion of the trachea. So now you have things that can get into the bronchial tract here. But this is an atresia with a fistula. Here you can have 2 connections. So you can have a narrowing, which we see here, and then we can have it connected to 2 separate areas of the trachea. Here we have, it's just basically showing that now the esophagus is connected
To the
trachea, but the rest of it isn't. So atresia means it's a narrowing or non-existent, so there it should be attached to its normal structure. Excuse me. And then you have 2 narrowings where they're just separated from each other. So there's different types. Something else I want to show you. Let's see if I can. All right, so Your book kind of shows the exact same thing. So there's like 4 different illustrations. They show an esophageal atresia and a tracheal esophageal fistula. So the atresia is the part that's short. The esophagus and the trachea connecting together would be the fistula. Does that make sense?
Yes.
So that's why they talk about the two together, because there's usually a separation of one of those structures from itself. All right. I didn't hear that. So hopefully that picture kind of helps to solidify, that particular process. All right, so if the mother already has a sibling or has given birth with a kiddo with TEF, then the likelihood of the next child having it is high. A twin can also, it'll affect one twin, but not the other. Okay. I don't know, someone's phone's ringing or what's going on. So they can have, if they have choking, cyanosis, and coughing, then they're at risk of secretion getting into the lungs. So they can end up, as I said before, respiratory distress, pneumonia, or end up dying. Okay. Other findings that you may have. So they talked about that rattling sound. What would that rattling sound be? What type of lung sounds?
Crackles, maybe?
It crackles or wheezes. It could be either or. Okay. So with feeding, they'll become tachypnic, they'll become distressed. They may have that excessive saliva, so they may require frequent suctioning. They could have crackles, they could have wheezes, they may vomit. If you continue to try to feed them, we already know about the drooling, okay? And depending on the type, they may have abdominal distension with type C and D, or they may have a flat or scaphoid belly with types A and B. So what type of diagnostic tools or diagnostic tests can we do? Diagnostic tools.
You can do imaging, or inserting like a feeding tube or a suction tube and X-ray or something, and you can see it coiled up.
Okay, so they can do a chest X-ray, like after putting in a nasal gastric tube. Then that's kind of to see with the position of the catheter. It also shows a dilated or air-filled upper esophageal pouch. It also shows pneumonia, so it shows us several things. They could do a belly scan. So that belly scan can also show them if there's air in the stomach. An upper GI series with contrast, or they can do a prenatal ultrasound. So that's why that prenatal care is important. Okay. They could do an esophagoscopy, which is basically can determine if there's any strictures anywhere in the upper pouch. They could do a bronchoscopy, so that's looking at the scope of they'll look at doing a lung scope to confirm the presence of a fistula being there. What would be the best position to put them in? Supine or semifowlers?
Semifowlers.
Semifowlers. So we definitely want to have them there. Are we going to feed them?
No.
So we're not going to feed them until after they get a repair. And after that repair, then we're going to gradually induce, oral feedings after surgery and things have healed up. So in the interim, we'll probably give them IV fluids and broad spectrum antibiotics. Why are we going to give them that?
They're going through surgery and they had an opening with gastric juices and stuff.
So until everything heals, we want to make sure that we're not causing an infectious process, especially for kiddos. So some of it will be prophylactic to reduce infection, and then we're going to give them oxygen therapy. Okay. So depending on what type of anomaly they have will determine the type of surgery they receive. Okay. Questions on TEF?
Hey, there was a question. What is a oral gastric tube?
An oral gastric tube is very similar to, it's a nasal gastric tube. Now with PD, they'll have a really thin, yellow, flexible, but weighted at the tip NG tube. So instead of going in the nares, it goes in the oral cavity. So it's the exact same thing.
Okay.
Okay?
Thank you.
You are welcome. All right, so outside of TEFs, correct. We're only focusing on the peds for TEF because that's where it would primarily be seen. Someone had a question about that. All right, so what else was on the list to cover?
Cellulitis.
Cellulitis and pneumonia.
Pneumonia.
All right. So tell me what you know about pneumonia. Well, first, how does someone get aspiration pneumonia? The cellulitis is immunity, but I'm going to talk about that a little bit because of tissue integrity. Dysphagia, okay. Dysphagia from what?
Maybe from sir.
I didn't hear that. Can't tolerate thin liquids, okay. Why?
There's misfunction of the epiglottis, so it does not completely prevent food or anything swallowed from getting into the trachea.
Okay, why? I'm not saying anything of what you're saying is incorrect. I'm basically wanting you to think about why or how that happens.
Patients who may be immobile or have other diseases or something that makes them incapable of maybe swallowing correctly.
So think about a patient that's had a stroke and their airway may have been affected. That's true. So this is why we can't give a patient something to eat or drink if they can't follow commands, because then whatever's in their oral cavity runs the risk of going into their lungs. So one of the more common forms of aspiration pneumonia is someone that's had a heart attack and then they vomited and then they inhaled it, and part of that vomit went down their trachea as well as their esophagus. Okay, and with that person, now we have, digested food that with acids that are now into the bronchial tract. Does that make sense?
Mm-hmm.
And there are
Yes.
many, many other ways that this can happen. However, that is from an inhalation of things out of the oral cavity or the gastric contents into the lungs. So my question is, does this have a low or a high morbidity? And what's
High.
Hi.
all right, what about mortality?
High too.
Okay, so what's the difference? What's the difference between morbidity and mortality?
Morbidity will be causing lots of diseases, and mortality will be death.
So morbidity is basically, think of it as it being disability. So that would be another disease condition, okay? So something that they will have to be treated for, lifelong. Mortality or treated for afterwards, not necessarily lifelong, but mortality is death. So aspiration pneumonia does carry a high rate of morbidity and mortality, because just think about the toxins that's coming out of your stomach going into the trachea, and your trachea is not equipped to handle anything like that, or your lungs. Okay.
Okay.
So, other types of situations that, that can bring on aspiration pneumonia would be what? What if a person has, been admitted to the hospital, they're ventilated, and that ventilated patient is has ventilator. How do they get ventilator associated pneumonia? I guess that's my question. So they've acquired an infectious process in the hospital, because there's, besides aspiration, we're going to talk about community acquired, and we're going to talk about pneumonia just in general.
Contaminated equipment, perhaps?
It could be contaminated equipment. I can see that. Hopefully not. I mean, hopefully when they did intubate the person, no one sneezed on it or rubbed their hair or they itched their eyeball or whatever the case may be. But the longer you stay in the hospital, the more likely moisture in the tube could be one. You're more likely to get some type of infectious process. That's why we talk about getting patients in and out safely but quickly. Okay, so usually if a patient's coughing or if they're choking while eating or drinking, drooling, then gurgling sounds when speaking, or hoarseness, that would be, how aspiration can manifest. You have different types of, someone said dysphagia, which is an impairment of any part of the swallowing process. So that will be another reason why an individual will develop aspiration pneumonia. So tube feedings, that can cause an aspiration pneumonia. Your own saliva can cause it. Vomitus can cause it. Either way, something ends up in the respiratory tract that doesn't belong. Does that make sense? Mm-hmm. Who are at most risk of aspiration pneumonia?
Patients with G-tubes?
Besides that, I'm looking at population types.
Elderly?
Elderly, okay? Especially if they've had a stroke, if the elderly person has dementia, Parkinson's disease, multiple sclerosis, then they're at risk of becoming dysphagic and they can have aspiration. Does that make sense?
Yes.
What about dentition? What if they don't have good, teeth? Or what is that, a dentism? So how sometimes you see people on the news and like a whole row of teeth are missing in the front, and then they have some in the back, or they may not have any in the back at the bottom, but some in the front at the bottom. So those types of things, because it means food has run the risk of improperly being chewed, right?
Right.
So they can gag, and swallowing reflexes can become affected, and now, the food that's in there can end up going down the trachea instead of going down the esophagus. Poor oral hygiene. So why would poor oral hygiene be a problem? What's the dirtiest part of your body?
Mouth.
Due to the bacteria. Okay. Your mouth is dirtier than your feet, believe it or not. Most people are like, no, it's not. Yeah, it is. Because you have food, you have bacteria that pools on in your mouth while you're sleeping. So those pathogens or those organisms that in the mouth can increase the risk of aspiration. All right, so how do you identify if someone does have aspiration pneumonia? What would be some signs and symptoms that the patient would display? What should we assess? Shortness of breath, okay.
Crackle.
All right, chest pain. And that would be more like a pleuritic chest pain, right? Crackles in the lungs, or, okay. Or anuchment.
They will cough when they eat or drink.
Potentially, yeah. But I'm talking about the actual assessment. What kind of assessment would you see from these folks? What would be their signs and symptoms? I guess would be another way of calling it.
Sputum production, elevated temperature, chills,
Okay, so temperature, I can go with that.
accessory muscles used during breathing.
All right.
Green sputum, yellow, funky.
Okay, now when we start talking green or yellow sputum, when we start talking about sputum in general, I mean, for pneumonia, different sputum types will yield different colored sputum. I mean, different types of pneumonia. So all pneumonia isn't the same, is what I'm getting at. What I'm saying is you can have a rust-colored sputum, and that would be indicative of a different type of pneumonia. So just FYI, all pneumonias are not the same. Discoloration in what way? So they would have, are you talking about more cyanosis, or are you speaking more of from what direction? Someone said cyanosis. I'm just trying to clear it up. Due to lack of oxygen. It depends on how far along the pneumonia is, but their saturation may be low. What does oxygen saturation really measure?
The amount of oxygen circulating.
Does it measure that, or just saturation of red blood cells?
The saturation of red blood cells.
Oxygen sats only measure saturation of red blood cells. Doesn't tell you what's attached to those little hemoglobins of the red blood cells. It's just basically telling you that it's being saturated. So you can actually have a patient that could be have an oxygen sat of 98%, but what's really saturating those hemoglobins could be carbon monoxide. Does that make sense?
Mm-hmm.
So just kind of think about that. Anyone that's passed out from drugs, from alcohol, problems swallowing, a brain aneurysm, stroke, all of those would be things you'd be looking for. Fever, cough, cough up either yellow or green, or it could be bloody. Doesn't smell good, so it's kind of stinky mucus. Fast breathing, so is that bradypnea or tachypnea?
Tacky.
Tachypnea. Okay. You could have, as time goes on, the discoloration, and you would see that to be circumoral, so cyanosis around the lips, or they could have cyanosis of the skin. Okay. How are we going to diagnose it? What diagnostic tool?
Chest X-ray.
Chest X-ray. What other labs should we get?
The CBC,
Okay, I agree. What are we looking for in the CBC?
elevated white blood cells.
Okay, either that or eosinophils or granulocytes. We're looking for those because they respond to infection quick, right? What else?
ESR.
I didn't hear that.
ESR.
An estimated SED rate, isn't that more for inflammation? Like inflammatory processes and things like that?
Yes.
You might want to do a sputum culture too.
Sputum culture.
Sputum culture, I will go with that. Sputum culture for sure. Blood cultures, just make sure it's not systemic. So this hasn't been going on a while. A bronchoscopy may be ordered, so they'll put in a bronchoscope, which is a little tube with a camera, and go look inside the lungs and see what's going on. And they may do a swallowing study. So those are things, someone with aspiration pneumonia, definitely rule out if they've had a stroke or something of that nature. or something's blocking the airway, then they can get that out. Does that make sense?
Yes.
So, with pneumonia, there are, what's the test that nurses can do that can let them know if there's consolidation in a lung?
Doing that palpating thing where you hit your hand. I forgot what it's called.
Tactile fremitus?
Sure.
She goes, sure. But tactile fremitus is one of the assessments you can do. So you basically put your hand over the patient's lung area, just hold it there, and have them say the sky is blue in Cincinnati. What tactile fremitus really means is if you put your hand on the back of another person and they're talking, you should be able to feel the vibration in your hand. If there's consolidation or something in the way, then that sound can't be transmitted, so you wouldn't feel it. Does that make sense?
Yes.
Okay, so that's what tactile fremitus, so you can tell them, the sky is blue in Cincinnati, anything. You see, want them to talk so you can see if you do have sensation in the palms of your hands. So that's kind of, something to think about. Okay. Also, not only do you have, the bacteria that's going on, the alveoli are swollen, they're filled with fluid. There's, white cells, red blood cells, macrophages, cellular debris, the microorganism, they're all in there. So they're clogging up the airway, which is the reason why this is a gas exchange issue, because if that's filled with gunk, what's not happening?
Gas exchange.
Gas exchange. Gas exchange isn't happening. All right. So we'll do more full-on pneumonia coming up, like community acquired, and, just people can have walking pneumonia. Pediatrics tend to have more viral pneumonia related to untreated respiratory infection. So URIs can definitely lead to pneumonia. Bacteria, then, we need to give them an antibiotic. How do we know what antibiotic to give them?
Culture and sensitivity.
Okay, what about it? What are
The
you
culture-
looking for on that culture and sensitivity?
Whether it's bacterial or viral?
Well, I mean, if it's bacterial, then you're going to have, whether it's strep or staph or pseudomonas or Klebsiella, H influenza. So all of it will be listed there. But what's significant about?
You want to know what medication to give.
Okay, so how do you know that?
Like you see, yeah, but you just for susceptibility and resistance. Like,
Okay, so you're looking at sensitivity or resistance levels.
Yes.
Okay, gotcha. And so basically when they do a culture, no matter if it's blood, sputum, or anything, or even wound, they first isolate the bacteria. Let's find out what the bacterium is, or the bacteria, if it's more than one. Once they isolate what the bacteria is, then they start to put that bacteria on antibiotic medium. So they still use those same, different Petri dish, but now this is a penicillin Petri dish. This may be a cephalosporin Petri dish. Then the other Petri dish may be, miscellaneous or fluoroquinolones or whatever. And what they're looking for is the Petri dish that has the most inhibition of bacterial growth. Does that make sense? The most inhibition of bacteria growth. So what it's doing, it is preventing the growth from happening on that Petri dish media. Why is that important?
That will probably kill the bacteria in the patient.
Because exactly, that shows how powerful it is in eliminating the bacteria. So if and the lower the number, the better. sometimes when you look at those and it says, hey, it's sensitive to, fluoroquinolones. We'll just use that for an example. But then, they may have another one where erythromycin, and it's, erythromycin is more sensitive, but they decided to go with the fluoroquinolone. Well, maybe the person is allergic to penicillin. Then they look at how is it going to affect the person's overall health. So if they have any kidney issues or anything like that, maybe that drug may be toxic to those areas. So they're not going to give them that one, but they're going to give them the next best one. It still kills. It may not be the best of the best, but it's still the one that will work for that patient. Does that make sense?
Yes.
So as nurses, it is your responsibility to do your due diligence as RNs to make sure that the patient is on the best antibiotic. All these antibiotics are not the same, and I've named several: penicillin, cephalosporin, fluoroquinolones. I mean, they're miscellaneous. There's several out there.
Mhm.
So just don't think you're never going to see them, because you do see them. You see them now. Levaquin, you see that. That's a fluoroquinolone. You see cephalosporins. So anything with cepha in it, ceftriaxone, cefapime, all of those are ceftriaxones. And some of those are, and they're generationally done. Some are first generation, second, third, fourth, fifth, sixth generation. Cephalosporins have 6 generations. The higher the generation, the more powerful it is, the more bacterium it kills. Does it make sense? So think about that as RNs. This is your responsibility now. It's not the responsibility, when you're, in this program, this is what your ownership to that process is. Looking at that microbiology to see if anything came back. Hang on one second. My computer's telling me it's about to die. Hang on. Saved by the cord. Moving on. So, questions about the aspiration pneumonia. Other nursing interventions you need to do is making sure they're hydrated, making sure they have mucolytics to help cough it up. They may need breathing treatments. Those are things that may also be a part of their management. What about incentive spirometry? What do you think about that?
They should use them.
Okay, so you just say, hey, Mr. Green, I need you to make sure you're using this incentive spirometry. It'll help your pneumonia get better.
No.
So you've done your due diligence?
No.
Okay,
have
so
to
what should
teach
you do?
Teach them how to
Hey.
use the spirometer and the breathing treatments. and
Well, their
how-
respiratory will cover them on the breathing treatments, right?
You
But-
want to, even after respiratory leaves, encourage them to cough and do deep breathing, and then reinforce, because respiratory will probably do the incentive spirometer, reinforce why they would want to do the IS to help them take the deep breathing so that it'll prevent their lungs from collapsing or getting atelectasis.
So what we're trying to do is prevent atelectasis. So what if you go in at 9 a.m., you tell your patient, hey, you need to do this incentive spirometry, and you go into the room at 10 o'clock and it hadn't even been picked up.
You just reinforce the teaching.
Reinforce the teaching, or is it your responsibility to say, hey, all right, let's go ahead and do some IS exercises?
Yeah.
You do it.
You do which one?
No, you do the incentives parameter with the patient right there, hand it over. You can hold it actually and give them instructions on how to proceed with it and make sure that they do it correctly to have the right rising, of the, the dells in it.
Correct. So basically, reinforcing the teaching, that's great, but it doesn't help the patient to reinforce the teaching if the patient isn't doing it. So we need to make sure the patient's doing it and then still reinforcing the importance of it and explaining, hey, if you don't do it, these are the things that can happen to you, which is not what we want to see happen. So, we don't want to see them stay there longer. We don't want to see them get a more significant infection than what they would have had. And, aspiration pneumonia in general, neither of the two is anything to play with. So, we've had 40-year-olds die of pneumonia. You've had, 4-day-olds die of pneumonia. You've had 80-year-olds die of pneumonia. So the key here is making sure that the right information is out there or given to the patient. And 2, that we follow up with the patient and make sure they've done exactly what we said. If we know they need to be on this incentive spirometry several times in an hour, then we need to be in there kind of facilitating that. All right, while I'm in here, let's go ahead and do a couple of incentive spirometry exercises. You can't get better if we're not doing this. So it's not like you're sort of forcing, but you're also, you should know the deficit if they don't do it. So if they don't do it, this is the outcome you're going to have. And so you need to communicate that as well. Okay? Anything else you can think of about aspiration pneumonia? I think you're good. I think we've covered all of the ins and outs related to that.
Yes.
Okay. All right. So what else was on the list? We've already did TEF. We've covered aspiration pneumonia. So tell me, how should you don sterile gloves? How should you don sterile gloves? How do you put them on?
Without touching the sterile part.
It comes with I guess a paper wrap. It's made of something. So you're going to open that. It's folded on the end so that you can open it with your bare hands without touching it. And that 1-inch perimeter, we should stay within that. And so we would pick up the first glove, and let me see if I can remember this. From the first glove, the cuff that's folded, that part, you can touch the inner side, having your thumbs sort of, your thumb up with one hand. I think it's your dominant hand you put on first. And so you want to touch the inner part of that glove as we pull it on, being careful not to touch the outside. And then once we have on the first glove, we will grab the second glove, the outside of the cuff, so the cuff is folded, the outside with our index fingers, and not our index fingers, our 4 fingers, and then we will slide on that second glove, being careful not to touch the inner part, the part that touches our hand. I can't hear you.
There we go. Has anyone looked to see if their Taylor skills book show you how to properly don sterile gloves?
Yes, it does.
Okay, I know it's in there. I'm just saying, have you guys looked?
Yes, we've done a module for Skills Lab for asepsis.
Uh-huh. Okay, so Paulette, or Suzette, not Paulette. Suzette, when you were saying that you use your four, it was Paulette.
Yes, it's
When you're saying that you're using your four fingers, what do you mean? Your
okay. So
finger, or are you saying that you cup these
that
four fingers?
those four fingers. That's what I mean. That's
Okay.
what I was saying. So
I got the picture. My point is, how many of you all do that? Or how many folks do you see and practice doing that?
I see a lot more people using 2 fingers instead of all 4 fingers, if that's what you mean.
Okay.
I honestly don't pay attention to how they're doing.
I like the honesty. I can appreciate the honesty. Okay. That's it. Only 2, 3 people.
I know how
I
to
don't
wear
see a
them.
lot of
I just
people
don't
doing
know how to
that correctly.
explain it.
Say that again, because 2 of you were talking at the same time.
I know how to wear them. I don't know how to explain it. Like
You know how to wear them?
yeah, but like explaining them, it's kind of, I don't know exactly how to explain how I wear them. That's the honest truth.
I mean, you got to know how you put them on. How do you know if you put them on correctly?
Ask the question again. I'm sorry.
She said she can't explain how to put them on, but she knows how to wear them. So my question is, how do you know that you're putting it on correctly? That's my question. Because you should, if someone says, hey, I've never used this before, how do I put it on? So at some point you have to talk to them, right?
Well, I can explain how to put them on. Give me 2 seconds.
Okay. Basically what I'm saying is this. There are a lot of individuals who put on sterile gloves incorrectly. So I see it every time I'm in clinical with my clinical students. I mean, the first glove you should put on is your dominant hand, and you use that wax paper, whatever paper it is that covers the gloves. There's a 1-inch perimeter, and that 1-inch perimeter, that 1 inch outside of that is considered not sterile. So can you use that packaging as a sterile fill? Absolutely, you can. However, what ends up happening is that people do not, they get the dominant one on, they do that one correctly. When it comes to the non-dominant hand, then they take their sterile glove and put it on the folded part where the glove is folded back on. And you can't, because even though it's in sterile packaging, that portion is considered to be non-sterile. You don't have to like it. It's just what it is. So every time that process is not followed, because some individual may not like it, you open the door for infection to happen to your patient. Because if you're willing to let that go, what other things are you willing to let go? And this is what I mean. So you're doing a Foley catheter on your female patient. You accidentally put the catheter in the vagina. You realize, dang it, it's in the vagina and not in the urethra, and then you put it into the urethra real quick. Is that sterile?
No.
Okay. Or you get the catheter tray, the Foley catheter tray, whether it's male or female, doesn't matter. You get the tray. You're handling the material that's inside the box just all kinds of haphazardly. You know, although there's a sheath over the tubing. Once you pull the sheath out, it's dangling and it touches your arm. Is that sterile?
No.
It isn't. We answer the question right, but in practice, do we follow the right thing to do? And that's where it's more important. Knowing the right, they already know you know the right thing to do. It's really up to you to make sure that it's followed through appropriately, no matter what somebody else says, because now you're just kind of opening the door. And this is the reason why we have things like vancomycin, resistant Staphylococcus aureus, and VRE, vancomycin resistance Enterococcus. So that's how these things come about, and why it's really difficult to get a lot of these bacterial pieces under wraps. For somebody with C. diff, can you use hand sanitizer? So that foam in and foam out stuff.
No.
You got to use soap and water. So you have to know which bacteria you can literally eliminate just from foaming in and foaming out, and then which ones you literally have to use soap and water. I mean, if you're dealing with any poo or anything like that anyway, you should do soap and water anyway. Just, you're going to, clean a wound before you go in. Even if you do the hand sanitizer, I would still do soap and water before I even put my hands on it. If I pull off the dressing, then my hands really isn't clean anymore. Those gloves aren't clean. So your Taylor book does give a video. It shows you a video. So when you go into Lippincott, it'll be on page 548, just in case. It'll show you how to don and remove sterile gloves. And, you're saying, oh, well, what's the likelihood of me having to use it? If you have a sterile dry to dry, wet to dry dressing, you're going to need sterile gloves. If you have to insert a Foley, you're going to need sterile gloves. If for some reason you're the caretaker of a person they think has Ebola, you better hope you know how to get those gloves on and off right. Okay? So, just food for thought. Foaming in, foaming out, very, very important to do. Hand washing, hands down, is the number one thing to prevent communicable diseases, period. And the reason why those folks in Sierra Leone, the Ebola was allowed to spread, is because they didn't use soap and water. Otherwise, that would have been eliminated. It wouldn't have gotten out as big. It would not have been as huge as it was a couple years ago. So soap and water is the key. And not cold water. I've done an experiment on that with cold water. It doesn't clean the same. So, if cold water is all you have, use it until, you can get something else. What about cleaning agents? What about those wipes that's in the purple top container? So it's the canister's white, but the top is purple. What are your thoughts about that?
In order for them to work, they have to completely dry. That's how I've been.
Oh, I'm looking at it that, some of it may be a carcinogen. I was just going to tell you to read the labels.
Oh.
Read the labels. I usually double and triple and quadruple glove if I'm going to touch those wipes, but it does have to completely air dry, air dry. And don't forget about what's the difference between iodine and chlorhexidine? Iodine and chlorhexidine. Which one's better?
Chlorhexidine.
Okay, chlorhexidine is an antimicrobial. It is better. And, that's the one you do north, south, east, west, or east, west, north, south. Iodine, the concern there would be with infection, with allergies. So that's always a concern, that folks may have allergies So, and you need to ask about that shellfish and all of that, right? Okay.
Mhm.
Okay. Anything else before we move on to a little bit of immunity? I think I've covered everything. Don't forget about tissue integrity. I didn't talk about ulcers. I think you guys have probably should be pretty well versed on ulcers, but you know, make sure you're turning your patients. Make sure you are. They have their SCDs. You check their heels. You check their bony prominences. You make sure their hands and legs are in functional positions. So that way it'll eliminate your patient developing a bed sore or of any kind, whether it's on the buttocks or not. Very simple. If your patient is one that, you know, can't control bowel or bladder, then what's the best thing to do? We'll start with bladder.
Use a pad.
Okay, so we use a pad. Some of the urine goes into the pad, but isn't the urine still in the patient's perineum?
Yes.
Yes.
So and so if it sits, then that brings on skin breakdown because urine is acidic. Same thing with poo. So if your patient has like diarrhea, maybe a rectal tube would be the best thing, you know? Otherwise, that's going to be a problem. So they're going to have all that skin breakdown, which is another potential of infection. Or them developing sepsis, which is something we don't want to see happen. All right, so let's move on to immunity. And let's talk a little bit about cellulitis. What is cellulitis?
It's an infection that came from a wound breakdown.
Okay. So there's some type of breakdown of the skin and the subcutaneous tissue. Anybody can get cellulitis. It can involve any area of the body, so it's not just prone to one type of folks. Although people that are more prone are those who have peripheral vascular disease or coronary artery disease or diabetes. Those are kind of be your top three. Is cellulitis viral or bacterial?
Bacterial.
Bacterial. What bacterium or bacteria is common in cellulitis?
Streptococcus.
Staphylococcus aureus and Streptococcus.
All right, strep and staph. Primarily the causative agent is staph. Everybody has staph on their skin. Everybody. It's when there's an overgrowth of the bacterium that you start having an issue. And this is why it can happen anywhere or to anyone. Okay? All right. So you would expect white blood cells to be up or down?
Up.
They would be elevated. Okay? And it was, I'm trying to think of your white cells. What's a normal white cell count level? That's what I was trying to think of.
1,000 to 10,000.
5,000.
5 to 10,000. So anything, if it was 9,500, would you be concerned?
No.
Why not?
It's below 10.
Because it's not what?
It's below 10,000.
It's below 10,000. Okay. So I would be looking at the white cell count the day before.
Yes.
What if the white cell count the day before was 6,000? Would you be worried now?
Yes.
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 Okay. So understand what that number means. Do your due diligence. So, okay, it's 9,500, it's within range. But if it was 6,000 a day before, okay, even though it's still within range, it looks like this bacterium is growing. And even if they're on a broad spectrum antibiotic, it may not be enough to, handle that particular bacterium. So, just, oh, we got the number we need, and then, we left. On the other side of that, say, for instance, the white cell count was 27,000, which would be high as crap, right? It's 27,000, but now it is 12,000. What's happening now?
The infection is being treated. It's going down.
It's going down, so the infection's being treated appropriately, okay? So those are the things you want to look at. If your white cell count, so we'll go back to that 9,500. If the white cell count was 9,500, then, and their eosinophils were 90, would you be concerned? Not eosinophils, they're neutrophils. Their neutrophils was 90, not eosinophils, neutrophils. Yes or no? So the white cell count's 9,500 and the neutrophils are 90. Would you be concerned? What's normal neutrophils? What's a normal neutrophil? What's the range?
Is it 2,500 to 7,500?
Too high. It's usually in a percentage. Normal 60 to 70. And that is in your skills book, in your Taylor book. Under the asepsis component, when you're talking about asepsis and infection. So it does talk about laboratory values that you need to investigate. So if the neutrophils were 90, I would say that this person has an infection, although the white cell count has not increased yet or hasn't gotten over 10,000. Something's brewing. Does that make sense?
Yes.
Okay. So you can't, don't think that there won't be any labs. I mean, there will be labs on these exams. There'll be electrolyte imbalances that may pop up related to diseases and conditions. So you got to know it. And these are, the CBC is one of the basic ones you should understand. Some of the others, like your amylase and lipase, they're going to be specific to conditions. But you should understand with the CBC, when it's elevated, the white cell count or low, what does it mean? Okay. All right. So more so, just make sure we're paying attention to those things so we'll know what's infectious, what isn't. So back to cellulitis. Signs and symptoms you would expect for the patient to have.
Pain, redness, tenderness, fever.
So pain, redness, tenderness, but more physiologic. What's their physiologic signs and symptoms? Will they have a fever?
Yes.
Okay, tachycardia, potentially, tachypnea. So those are things that you may see when you have, cellulitis in play. Without prompt treatment, how would the patient respond? Will they get better or worse?
Worse. The area
They,
would
they
get bigger.
can develop septicemia and they can end up dying. So a couple of semesters ago, that actually happened to a patient, but he had a lot of vascular coronary artery disease or coronary artery disease, diabetes, peripheral vascular disease, and he came in with a cellulitis. It was weeping, his leg was red and swollen, and he ended up dying. Most of the organisms are gram-negative organisms like E. coli and Pseudomonas. It could be a fungal infection, depends on, the situation. It can happen, you can develop cellulitis because it's an extension of a skin wound or like an ulcer or from furuncles or carbuncles. What is a furuncle? Furuncle. So it's like uncle, U-N-C-L-E, but F-U-R in front of it. What is that?
Infection or boil?
Infection of the what?
What I'm looking at is an infection of the hair follicle.
It is it's a
boil.
deep folliculitis, which is, an infection of the hair follicle. So basically, short word would be a boil. Okay. So pus is underneath that, dead skin is underneath that. All right, what is a carbuncle? So car, C-A-R, and then, or carb, and then uncle. What is a carbuncle? What is the difference?
It's a group. It's a
It's
lot
a
of.
group. Okay, so look at it this way. If you can't, it's like, I don't know the difference between a furuncle and a carbuncle. How many fur coats can you put on? One. So that means that's just one area. It's a boil, but it's one area. Carbuncle, you can load it up, more than one passenger. So that means it's multiple boils or multiple collection infections of the hair follicle. So red, swollen, painful, blisters, all of the whole nine. So pus is underneath there and everything, but it's a collection. So if you want to go with C, carbuncle is a collection of boils, okay, that's fine too. Okay. All right. What if someone injured their leg, say they had an abrasion? Who would be more at risk for developing cellulitis? Who would be more at risk for developing cellulitis if they had an abrasion to the leg?
The elderly?
Okay. I can see that. What about diabetics?
Them too.
They have them too. They have delayed wound healing. So anybody that's a diabetic, you have to make sure that what is under control? Their blood sugar level. Okay. Usually cellulitis is to the lower extremities, and they do respond highly favorable to antibiotics. So that shouldn't, no one, unless there's some other issue going on. there are common skin infections or disruptions that are thought to be, chronic immune responses to unknown antigens. So you can have a dermatitis, but there's some kind of, you're not really sure why. And that can lead to, different types of skin problems. Like I cannot wash any of my clothing in Tide. Tide breaks me out and I'm itching all over the place. Does that make sense? Some folks are allergic to nickel, and nickel is in everything we use. Your buttons on your jeans, your buttons on your pants, your belt buckle, that has nickel in it. So if you're, sterling silver, that may be another agent that your skin may be irritated to and you just don't know why. Bubble baths. Some folks are allergic to the bubble baths. So those types of immunologic reactions are just when the skin there's an indication that the skin's been irritated from a foreign substance. And so they have a red rash, or it's red, or erythematous, hives. Those would be things you may see, a lot of itching. What about psoriasis? Because that's under skin integrity. What's significant about psoriasis? What's the hallmark sign of someone having psoriasis?
Flaky skin?
I said, what is the hallmark sign of a person with psoriasis? And Latricia said silvery scales, which is true. That is a hallmark sign. Okay. Oh, Erica said that. Okay, got it. Sorry. So looking at all those pieces, and there's so many other skin disruptions. You could have impetigo, which is a bacterial infection. You can have thrush, which is from candida, or yeast, which is the same yeast for jock itch, same yeast for yeast infection. It's the same one. Okay. So sometimes, somebody with psoriasis, they have these exacerbations and remission, so it's recurrent. And although there's a small amount of the population that's affected, there seems to be a lot of people that may have it. So it's not like it's highly, one of those high types of skin conditions, unlike eczema. That, there's a lot of people with eczema. All right. So when there's an infectious process with cellulitis, then the skin and the mucous membranes, they can be damaged and result that could be from a bacteria, virus, or a fungus. So either of those. Small abrasion or lesion can provide an avenue for any opportunistic infection to happen. And remember, it's of the skin and the subcutaneous layer. So things that affect the skin layer, which is the epidermis, can also involve just the dermis, which is right below. And that would be your cellulitis, which is inflammation of the subcutaneous tissue. Impetigo, which is usually caused by Staphylococcus aureus or a beta hemolytic strep. Those are common superficial bacterial infections, and they're easily spread amongst kiddos. So you'll see that there. So other things that can impact or be impacted by cellulitis would be your electrolytes, comfort, pain. These would be some other concepts or interrelated concepts. That was the word I was thinking of. Thermal regulation, elimination. So those would be additional ones. Okay. So what are we looking for? What would be some signs and symptoms of cellulitis? What would be some history that's related to tissue integrity we want to inquire from our patients? Any change in pigmentation, changes in moles, dry skin, moist skin, any skin diseases. We should culture them before we give them meds. That's a good one. Other things we want to ask them would be, do they have any itching to the area, bruising, excessive bruising? Could it be an allergic reaction before we get down to the cellulitis component? So rash, lesion, hair loss, what kind of medications, environmental hazards, those would be some additional assessments we want to look at. You can get a staph infection just going to the gym because people sweat. They don't wipe all that stuff down. Then the next person gets on. So, make sure you're paying attention to that. Even those dumbbells, same thing. Okay? Just saying. Look at the skin to see if it's pink, warm, dry, if it's normal for their skin tone. Does it look like it's infected? Does it look like it's gangrenous? I mean, all of those are things you want to be paying attention to. How do you describe your lesion? What should you use to help a person understand how big a lesion may be?
Measure it.
Using what? Using what? I agree with measuring, but what are you going to use to measure?
A Q-tip.
Okay, so I have a wound this big.
Okay.
Tell me how a Q-tip's going to help me.
The tape measure from the Q-tip. The packaging that the Q-tip comes in.
Okay, how about an L ruler? So it gives you, length and width. Or what if you said it was golf ball size? What if it was tennis ball size, dime size, nickel size, egg? Do you see how that's more tangible? So, and then there are some facilities, if they have a wound care department, then they have, they have a wound circle ruler that they use. So those, you want to have something tangible, not say it's a big circle, it's about the size of it's ovoid. I mean, that's good, but how ovoid? Does that make sense? So make sure that you're giving some, good readings. Does it have pus? Any discoloration? Is it bleeding? Does it have an odor to it? So you want to identify those things. Feel around it to see if it's hard or if it's cracking. Making sure that the skin is still supple. Other things you can look at, if it's warm, hot, red, painful to touch. Does it seem like, it may have some lymph involvement, like lymphadenopathy or streaks? So you can have cellulitis, as I said, to the lower extremities. You can have a buccal, periorbital. Those are regions where cellulitis can develop. Purple discolorations of the eyelids can also appear with their decreased ability to move their eyes. So if they have a periorbital infection, you want to look for lymph node enlargement, fever, headache. Those are all some signs and symptoms with cellulitis. Antibiotics for sure. They're going to need that no matter where it is. They may need, depending on how significant it is, hospitalization may be required. They may get some topical steroids, that's usually given for an allergic dermatitis to get rid of the itching, or for hives. Emollients they could use, that's kind of those, more like a paste. It has less water to it. So lotions has more water, ointments and emollients are much more thick and much more, provides a lot more moisture. All right, making sure we clean and dress the wound appropriately. So if this is your patient and your patient, the surgery team's gonna come in, the surgical residents, and they're gonna do a debridement. When should you medicate that patient?
30 minutes before.
20 to 30 minutes before. So, don't I have the pain medicine at the bedside. It's going to take 10, 15 minutes for it to work. So by the time they get done, that 10, 15 minutes is already passed. So know what kind of dressing you need to do. If it's dry to dry, wet to dry, occlusive, colloidal, all of those things are things you want to look at your physician's notes. Monitor for venous ulcerations, monitor for gangrene. A lot of times cellulitis comes with folks that have peripheral vascular disease, so their leg will be swollen, pain, and red. All right, any questions about cellulitis?
No.
Yep, all of those. All right. So be ready to talk about some osteomyelitis. Have you worked on your case studies that I sent you, your puzzle? Or that's on your list for today?
Working on the puzzle.
Okay. All right. Oh, all right, Latricia, she said, I did that puzzle. That was hard. Okay. I bet you understand a lot more about your medications and everything from that one puzzle. But it was all based on that article. So if you read the article, then you should be able to, answer all of those questions. Okay. Well, if you guys don't have any other questions, I covered the top 3 objectives. So we will start with those case studies we'll start with those on Tuesday morning at 9, unless there's something else you need to ask me.
Questions and answers, please.
I've asked you a bunch of questions throughout this whole process.
You know what we mean.
But I did, though. I just infused them into the lecture this time instead of just having a separate section. But, you guys got to read the material. You got to look at it before we come face to face. You need to have it read. If not, you already behind the 8 ball. So, if you're not answering the questions, then that's telling me you didn't understand what you read, but you're not going to say anything, or you just didn't read it. I don't expect you to know an answer to everything of what I asked, but just try and work on, understanding how do I put all these things into perspective? How do they all connect? How is this a gas exchange issue? How is this an immunity issue? Because now you got to look at the vaccines. So you need to look at, the different types of immunity, whether it's passive, whether it's active. You need to understand that. So those aren't going to, just go away. So you need to have a clear understanding about that. Does that make sense? So yeah, there's a lot of things. I did email. Erica's been sending me an email, or it wasn't Erica. It was wasn't it you, Okeezy?
Yes, ma'am.
Okay. I did email Mrs. Johns. She should have it up for you guys. Within the next day or so. So what I can tell you, and I apologize, someone's getting ready to play tennis and they had the leaf blower out. Let me look at that. Pull up my immunity exemplars. So vaccines, otitis media, urinary tract infection, cellulitis, and I just covered that, osteomyelitis, pneumonia, appendicitis, and trauma sprain. Those are all of your exemplars. So I'll repeat them again. Vaccines, otitis media, urinary tract infection, cellulitis, but we did that one today, osteomyelitis, pneumonia, appendicitis, and trauma sprain. Those are your exemplars. And I believe your exam two, let me go back here, get the calendar. Your next exam is March 18th. So after this Tuesday, the following Tuesday is all acid-base. So your only J1 concepts is tissue integrity and human development. So after we do immunity, that will be our other, and then acid-base will be by itself. But since you guys only have an hour and a half of class, you actually have to, you know, spend the time getting all these things locked down tight. One other, do you all know how to use your Lippincott resources? Yes, no, maybe, hadn't thought about it.
We're still working on it.
Okay. Basically with Lippincott, everything of what you need is there. So if you're not, you know, spending some time in it, then it doesn't really help. Close that. You go to Lippincott. Yeah. Let me see if this will. If I'm still logged on. We'll find out here in a sec. All right, so I'm going to share my screen. And there we go. All right. So can you see my Lippincott course point?
Yes.
Yes.
Okay. So I have J1 just as well. And I also have the things that are in the J2 concept. So what I would do if I were you guys is the following. When I am looking for, you know, what I need to study, I usually just click on, when you go here, go to concept view. Naturally. All right, so under concept view, you'll see your course, second level bridge, and then this should pop up. Have you guys seen that?
Yes.
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 So we'll go to human development. So under human development, you have developmentally delayed. So it'd be like your Down syndrome, your cerebral palsy, you know, they may fall up underneath that, but your two exemplars are the hospitalized individual and developmental delay. So I would click on those exemplars. All right, so what you have available are journal articles. So they look at kiddos with special needs, you know, the adaptive functioning for preschoolers, the genetics, the surveillance related to pediatric patients, and it's kind of a list. So these are articles, but here's your ebook. So this is all of your reading. I'm going to eliminate journal articles. That's just like kind of FYI. You're not responsible for the journal articles. Let me make that clear. But what you are responsible for are these readings. So you should read, 149 to 154. It's an overview of disability. Page 1002, and it tells you the book. That's your RISI book. This is your RISI book. This is your RISI book. So basically, after you read 1002, then you're going to go to 1031, then you go to 1129, 1131, and then, as you can tell, it goes in succession. But the last four are in the last 4 or 5 are in your RISI book. I'm going to click here for the overview. And what it should do is take me to it should take you to your Lippincott resources. So when you click on there, this is where it should take you. So here's the framework for preventing chronic diseases and health promotion. Now, if you're wondering if you're in the right place, go back. It should be pages 149 to 154, correct? So here I'm on page 149 if you look at the bottom left. And if you scroll up, this is all page 149. So all of these things, but they're kind of getting you down to where you need to be. So starting here with this health assessment, and then here are nursing care for special populations. So this is where you would actually start, right here. I'm just gonna highlight that. So you start there, you read about it, and then to get to the next page, you click down at the arrow down button. Here's your overview of disability. So you continue and what the impairment is, prevalence. They give you a little summary, characteristics of disabilities. Here's a chart. And they're talking about multiple sclerosis, secondary health conditions like ulcers and UTIs and blown bone density based on their disability. So this is what you should be reading all the way to page what? 154. And then you stop. Don't keep going past 154. So here we're on page 152. So it talks about the ADA, questions to ask to make sure that you are, providing quality care for your disabled folks. And then you keep going. They have aging and older and young. So last one here is 154. So, barriers to healthcare, interacting, blah, 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 blah. I think you get my point. Speech difficulties and seeing are 2 different disabilities. And it amazes me when people are around folks that are blind, they're screaming at them like bloody murder. So, just be mindful. Blind doesn't mean deaf. Deaf means deaf. All right, so now if I'm looking at my pediatrics, then here's my growth and development table and my RISI book. So I will click there. Now I technically wouldn't have to click there. I gotta wait for this to roll up. I could have easily have just used my my previous course point pages. I could have just gone here and then gone to my library and then gathered my RISI book. Scroll down, here's my maternity. I think that was 1002 is the page number. So once I came down here at the bottom, then I could do put in 1002. Let me find out what's the actual title. Table 26.4. Okay. All right, so let me go back to here, and I could type in table 26.4. So signs of development, mental delay. And then here's everything of what you need. Here, this is your table. Okay. So if that is the only place where it's telling you to go, that's the only thing you need to do. If there's a range, then you look at the range. Then it goes to the next table, which is on 1031. Then your next piece, when you're looking at the health supervision, now you have a couple pages to read. This one is just one page, so it must be, something just specific to that. Does that make sense? Yes, no, maybe?
Yes.
Okay. So they have everything here for you. There's no reason for you to be going all over the place. Just try to stay focused on what you already have. Some of these will have interactive case studies listed, on the left-hand side. Unless you're interested in the skills mastery, these are actual skills. So now I'm going to go back to the human development concept. I'm going to look at the hospitalized individual. And then again, these are your resources. The only thing I'm going to look and see is what my reading is for the ebook. And then these are the readings for that. So RISI book, and then the mental health book, which is VitaVec. So if you are in Course Point, or in your VitaSource, then, when you scroll down, here's VitaVec, and that's your psychiatric and mental health, and you would click on it to open the book. And then it would take you to whatever respective pages you wanted to go. Okay. So that's how you utilize Lippincott. And, you should be A-okay. I'm going back to the concepts. The other one we have is immunity. We'll look at acid base. We'll look at something that's coming up. So here you have the Lippincott advisor you could use for acid base. And so you can, go to acid base here. It'll take you to the Lippincott advisor for education. And so here I would type in, I would choose diseases and conditions. And then I would type in acid base because I don't see it here. So I would type in and hit enter. And so it talks about blood gases. It talks about, and these would be the things you need to look for: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So this is actually giving you all of the electrolyte imbalances, like the phosphates. So I'm trying to get down to the M's. But those will be the 4 pieces that you want to look at for your acid base. So when you go back to your Lippincott here, these are the 4 things you'll be looking at: metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. These are the 4. Now, you need to understand how to determine those things, but that's how your exemplars are set up. And so then you go here, and basically that's your education for Lippincott advisor for education, or you can go to the textbook, but this is going to cover everything of what you need to know. And if you paid attention when back here, this is actually telling you when something is in metabolic acidosis. It's usually a person with diabetic ketoacidosis, acidosis. Metabolic alkalosis would be someone with GI losses, so vomiting, diarrhea. Wouldn't that make sense? Yay, nay, maybe.
Yes.
You're like, not this week. So respiratory would have to do with whether they're not ventilating or ventilating too much. And that would be for any of your concepts. So even if I went back to content by concepts and I chose immunity, which is coming up, oh, you don't have it, dang it. Let me go back. Spoke too soon. This is what should be there. I don't know if I have it. Let me see if I can get it. It may tell me no. Huh. It wasn't in that one either. Wow.
It's not my fault. I didn't start that minute.
Interesting. Someone found it through PrepU. Okay. That is interesting that it wasn't selected. Well, I don't know if I can actually add it either to a collection, because I don't have rights to that collection. So, Lo Siento, sorry about that. My apologies. But what I will say, hopefully she will, Mrs. Johns will get that up, because you guys do need that for this week as well. But I'm glad I sent out those case studies to give you something to work on, because I can't even tell you the books to use or the pages in the book.
Go by concepts view, you can find it.
I'm sorry?
If you go on concepts view, you can find it where it lists all the concepts, and it's on
Here's the
there.
concepts here. So where are you speaking about?
I found it on the PrepU, under PrepU, and then you call concept by concept under PrepU.
Okay, so
yeah, it's right
PrepU.
next to the tab that says PrepU.
Oh, content by concepts. Okay.
That's how I found it.
Well, there you go. I'm glad you said something, because now anybody that watched the video, they can see it too. So here's immunity, and that's something. Guys, smarticles more than the teacher. Here's cellulitis. Here's osteomyelitis, pneumonia, otitis media, urinary tract infection, and vaccine. So those would be the things that you would be, and trauma sprain, that you would be responsible for. So if we did osteomyelitis, they don't have any other resources besides the book, but it'll at least tell you where to go in the book for it. Does that make sense?
We can't see what you're showing.
Oh, did I stop sharing screen? Hold on. I did. Let's see. Let me go back. Can you see the concept now?
Yes.
Yes.
All right, so let me go back to how we got to this point. So what I did is I went to content by concepts. Let's see if it'll do it now. It's probably saying, we hate you. Oh, and then here's immunity. And then I gave you a list of the ones you'd be responsible for. So appendicitis, cellulitis, osteomyelitis, otitis media, pneumonia, trauma sprain, and UTI and vaccines. So you have a lot of exemplars. So if we looked at appendicitis, this basically gives you the Lippincott for education, the Lippincott advisor, and then you can look at the ebook, and this would be all the things that you would look for here. But your focus here is appendicitis. So that's the only thing that you would need to focus on. So how does appendicitis come about? How do you treat it? What's your signs and symptoms? What's your diagnostic studies? That's how you would look at appendicitis. Cellulitis, you go to the ebook. Again, it talks about skin wound care, the integrity, and they're actually pulling things from the fundamentals book. So it's not all in Brunner. Then they pull some things for pediatric or from the Reese book, your patho book, antibiotics from pharmacology. So, look at those, that material. So when I go back to immunity, the next one would be osteomyelitis, otitis media. And what I'm actually looking for is something that has, I was hoping they had like a little something that said interactive case study so you could see it. But here you can look at red flags about the ear. You can look, those are articles. Don't get down into the minutia. Basically walk away with a general understanding of what otitis media is, the different types, viral and bacterial. How do kids present when they have it? Adults as well. What do they complain about? What signs and symptoms? How would you treat it? Those would be the things that I would look at. And discharge teaching. So I wouldn't get too caught up in it. Here's a practice and learn interactive case study. So here's one on pneumonia right out of, your book. So you launch it. There's your objectives. There's 19 questions. You go through it, and they're going to ask you some antibiotic therapy, respiratory diagnostic studies, signs and symptoms. So that will help you understand pneumonia. Does that make sense, guys?
Yes.
So you shouldn't have to go, all over the place. You have the resources there. This is very comprehensive. But these case studies definitely help you put those pieces together. And that's the reason why I sent you guys case studies. So you may not like them, but that lets you know how much of this you really do know. And it's more than just answering the question. It's all of the information that's surrounded around answering the question. That's just as important. What if you had a different sign or symptom? What if the sputum color was completely different? What type of pneumonia would you be looking at? And that is important because, there's some pneumonia that happens from HVAC systems, and that's called Legionella or Legionnaires pneumonia. So just saying. All right, I'm going to stop sharing. Questions, comments, concerns?
Well, it's just a comment. I was able to assess the pneumonia part from the concept, the section you went to, because I realized that on that weekly reading list under pneumonia, when I looked at that book and the pages, they talked about diabetes.
Oh, this is why personally, I don't put out reading lists. Lippincott already has broken this down. And to minimize drama, when they update the book, they update all your resources. So, as a faculty, you could be way off base because something's moved. They may have changed that chapter. And you may not think about changing the reading list. So I would just say DX the reading list. Go the way I just showed you to go. Click on your click on your concept, your exemplar, and when you click on the exemplar, then look at the pages for that exemplar. And that will help you not get lost in all, and there's so many resources, you can easily get lost in here, but just keep it simple. And if the pages aren't right, then you're looking at stuff that you're wasting your time looking at material that you don't even need to look at.
Sure.
So I apologize for that. You know, someone asked a faculty instructor about a reading list, and she said you need to read it all. I said, okay. But reading lists, they're good and they're bad. They're good because, you know, yeah, you know where you're going, but it's bad from this standpoint that when the book changes, if you don't update it, now you have another, you know, you have another problem on your hand.
Okay.
Okay. Sorry about that. I thought my dog was about to vomit. So I had to look out here real quick. All right, guys. We'll see you Tuesday. Enjoy the rest of your Sunday.
Thank
It was
you. You
helpful.
too.
Thank
Oh.
you.
You're welcome. Bye-bye.
Bye.